Okay. Thanks for the warm welcome, everybody. It's a real pleasure to be in Auckland and to talk to you today about some work we've done looking at our registry over the last 17 years. We've had an out-of-hospital cardiac arrest program running since 2000, and we have a report that is imminent to be released. I hoped it would be available for this conference, but keep an eye out. I'm just going to present some highlights from the report to you today. Firstly, I'd like to give a little bit of context about the size and population distribution in Queensland. This year we welcomed our 5 millionth Queenslander. The majority of the state lives in urban areas along the coast. However, of all the states and territories in Australia, Queensland has the highest proportion of our population living in regional or remote areas. So 37% of Queenslanders live outside the metropolitan centres. We've got a highly decentralised population over a very large state. The state of Queensland covers almost 1.8 million square kilometres, and as I mentioned, most of the state lives along the coastline. But we do have large clusters of population, significant distance from Brisbane. For example, Mount Isa is a city of 24,000 and it's 1,800 kilometres from Brisbane. So we've got a workforce of about 4,000 paramedics that are employed right across the state. And as you can imagine, having a population distribution like this really presents some challenges for service delivery, particularly when we're talking about a time-critical cohort like out-of-hospital cardiac arrest. Just a quick profile of our cardiac arrest cohort. It's very similar to what you've heard before. Around 2/3 are male with a median age of 65 years. Consistent with the usual patterns of the ageing population, there are more women in the oldest age categories, so that red bulge on the right-hand side represents females over the age of 70, and the excess rate in males under 50 is mostly attributable to trauma. I want to talk a little bit about the chain of survival, particularly as it presents challenges for a highly distributed state like Queensland. Firstly, with regards to response times, the QAS has a median response time between 8 and 8.5 minutes. That's a statewide figure for cases where resus is attempted, and in metropolitan areas, nearly 2/3 of all cardiac arrests are responded to within 10 minutes. Across the time period of our study, QAS out-of-hospital cardiac arrest patients with an initial shockable rhythm on arrival of paramedics were defibrillated between 9 and 12 minutes of the 000 call being received, which is a good result considering the distance that we have to travel in many cases. As we know, early advanced life support is really important for identifying and addressing reversible causes of out-of-hospital cardiac arrest, and it's been shown to improve both short and long-term outcomes. In 2016, in out-of-hospital cardiac arrest cases where resuscitation was attempted, we had an ACP clinical response as a minimum, and in addition, 78% of these cases had either a critical care paramedic or a medical officer in attendance. So the majority of out-of-hospital cardiac arrest patients in Queensland receive the benefit of a very high advanced skill set within our care model. If we look at our most recent figures in 2016, out-of-hospital cardiac arrest rates in regional and remote parts of Queensland outnumber those in metropolitan areas by approximately 40%. So we're actually experiencing the greatest growth in arrest rates in areas further away from the metropolitan area. 143 per 100,000 in our remote areas compared with 104 per 100,000 in metropolitan. So these growing rates, especially in regional and remote areas, highlight the complexities and challenges associated with the delivery of care across our state. Just a quick look at the causes of cardiac arrest. As you can imagine, the leading cause of cardiac arrest in adults is presumed cardiac etiology. Around 2/3 or 65% of cases attributed to a cardiac cause. But when we look at the profile for paediatrics, it's a markedly different profile, with presumed SIDS being the cause for about 1/3 of cases, followed by trauma. Only 4% of children were identified as having a primary cardiac origin. But this requires evidence of a congenital heart problem for children in this young age group. As many of you would be aware, out-of-hospital cardiac arrests are most likely to occur at home. Only 11% of those in our cohort occurred in a public place. However, we do know that the outcome of out-of-hospital cardiac arrest is heavily influenced by the location of the arrest. The location will usually affect whether the event is witnessed, whether bystanders are close by, and the subsequent activation of emergency care and timely resuscitation. As you can see in our chart, out-of-hospital arrests in public places are more likely to be bystander witnessed, and our analysis also shows that out-of-hospital cardiac arrests in public places are more likely to involve a younger cohort with a median age of 52, compared with nursing homes with a median age of 81 and private residences 67 years. So this also increases the likelihood of survival younger age. The next section, I'm going to drill down a little bit onto the key features that we know affect outcomes. And firstly, I want to have a look at bystander CPR rates. In Queensland, they've steadily increased over the past 17 years. If we look at the blue line, of all cases of cardiac arrest that were witnessed by a bystander, 54% received bystander CPR in 2000, and this increased to 64% in 2016. The gold line represents witness cases where a resus attempt was made by paramedics, and here bystander CPR increased from 58% to 77% in 2016. It's a really interesting chart that explains a little bit about a phenomenon that we're spending a bit more time looking at the moment. Over time, the proportion of out-of-hospital cardiac arrest presenting in shockable rhythms has reduced, and this is despite increasing bystander CPR rates. If we look at the green line, once upon a time, arrests in a shockable rhythm made up 39% of cases where resuscitation was attempted. However, in 2016, shockable rhythms only represented 27% of these cases, despite there being no variation in response timeframes and decreasing overall resuscitation attempt rates. We've observed declining resuscitation rates over the years, from 54% in 2000 to 41% in 2016. Those figures aren't on this chart. That's except for cases where bystander CPR is a feature, and these actually increased from 48% to 60%. This demonstrates the increasing ability of QAS paramedics to apply judgment and identify appropriate cases for resuscitation and to withhold advanced measures when they're likely to be futile. So taking into consideration the overall trends in increasing age and chronic and complex disease amongst the population, it's likely that this observed increase in non-shockable rhythms is probably a result of that phenomena. So looking at the time to defibrillation part of this slide, amongst our out-of-hospital cardiac arrest cases, the time taken to deliver the first shock has varied between 9 and 12 minutes over the time period. There's no real clear trend apparent, although it does appear that there are some outlier cases that may be moving the 75th percentile higher. And that would be expected in a state like ours where we do have some pretty long transport times. In an environment of increasing demand for ambulance services, high levels of metropolitan congestion, and a population that lives remotely from major service areas, the consistent delivery of an initial shock within 12 minutes of the 000 call is really quite a good result. Sorry. So how do these patients fare? The rate of survivors as a result of QAS resuscitation efforts has doubled from 2000 to 2016 as a result of some substantial clinical and system improvements over time. This is particularly the case amongst out-of-hospital cardiac arrest cases presenting in a shockable rhythm, with this group of patients now twice as likely to achieve ROSC at 48% than patients presenting in a non-shockable rhythm. Obviously, whether the arrest is witnessed or not plays an important role in the prognosis. Here we're looking at out-of-hospital cardiac arrests that received a resuscitation attempt by QAS paramedics according to their witnessed status. So almost half of all paramedic witnessed events now achieve ROSC at hospital, and this is a 50% increase since 2000. ROSC at hospital for bystander witnessed events has doubled from 18 to 36% across the time period. And even amongst unwitnessed events, despite having a much lower overall ROSC rate, it has more than doubled from 10% to 23% in 2016. QAS paramedics have demonstrated greatly improved clinical judgment in terms of selecting appropriate patients to commence resuscitation, with resuscitation for out-of-hospital cardiac arrest cases of cardiac origin reducing from 40 to 27% across the study period. Evidence of this decreasing resuscitation rate being a result of enhanced clinical judgment lies in the corresponding increases in ROSC and survival to discharge rates amongst the same patient group, indicating that paramedics are increasingly making accurate clinical decisions on where resuscitation efforts can be maximised and avoiding futile resuscitation effort. In 2016, 34% of these patients achieved ROSC at hospital, which was an increase from 18% in 2000. And importantly, survival to hospital discharge has approximately doubled since the year 2000 in Queensland, from 9% to 16%. To examine and compare system performance, we use the Utstein survived event rate. According to these definitions, in 2016, the QAS achieved a 52% survived event rate for bystander witnessed patients who present in a shockable rhythm, and of these, 31.3 were discharged alive. Unfortunately, patients with non-shockable rhythms demonstrate far less favourable outcomes, with a 26% survived event, and of these, only 3.8% were discharged alive. And these figures are pretty consistent across jurisdictions. They are a group that fare far more poorly. These are all bystander witness cases. Therefore, it is important to develop strategies to address the gap in outcomes between those that present in VF and VT and those that are not amenable to defibrillation. Interjurisdictional comparisons tend to focus on the groups most likely to survive, that is, those that are witnessed and presenting in a shockable rhythm. By applying the Utstein definitions to Queensland data, only 14% of out-of-hospital cardiac arrest cases where resus was attempted and were witnessed actually present in a shockable rhythm. So this represents a very small proportion of the total out-of-hospital arrest cohort. Almost twice as many witnessed arrests present in non-shockable rhythms, and the rate of these presenting rhythms is growing. And this is a group most likely to benefit from high-quality early bystander CPR. So what are the main take-home messages from our report? Number one, our ROSC rates have almost doubled between 2000 and 2016 and now sit at 37%. Secondly, among patients presenting in shockable rhythms, ROSC rates have more than doubled from 26% to 53%. And perhaps most importantly, survival to hospital discharge has approximately doubled since the year 2000 in Queensland. This equates to 226 individuals who survived an out-of-hospital cardiac arrest in 2016, compared with 100 survivors in 2000. In real human terms, this is an extra 126 people who return to their community, their family and their friends. The gentleman in the centre here's name is Dale. He's an ICU nurse and he's an out-of-hospital cardiac arrest survivor. The other two he describes as his heroes. They're strangers who performed CPR at a service station until QAS paramedics arrived. And I think he's back at work. So moving beyond this report, the QAS pre-hospital reperfusion program celebrates its 10th year of operation this year. It began as a consult-led program for intensive care paramedics to administer fibrinolytics in the field, and it's now developed to include consult-led thrombolysis for all advanced care paramedics in Queensland. Our critical care paramedics autonomously deliver fibrinolysis, or they facilitate early referral to primary PCI following the identification of an acute STEMI in the field. In 2016, QAS paramedics successfully made 460 referrals to primary PCI, with an additional 93 administrations of pre-hospital fibrinolysis following the early recognition of a STEMI. An important part of this strategy is our partnership in the Queensland Cardiac Outcomes Registry, or QCOR, which is a collaboration that collects and reports on the delivery trends and outcomes of cardiac interventions in Queensland. And we're also collaborating in the AUSROC registry as well. In terms of CPR, we've conducted CPR masterclasses for our paramedic workforce to promote high-performance CPR, and that's certainly on our agenda into the future. And we have a really big focus on harnessing the community capacity in the area of CPR awareness and skills. We have an active community CPR awareness program, which is promoted through our local ambulance service networks and volunteers, as well as our paid staff. In 2016, the QAS trained approximately 30,000 Queenslanders in CPR skills. We do this because the majority of cardiac arrests happen in the home, to family and to the people we love, and recognising and commencing early CPR gives them the best chance of survival. Our CPR awareness program is flexible, it's low cost, and it's delivered across the state in many settings, employing a variety of delivery methods. Many of our local ambulance committees run regular CPR awareness training sessions free of charge in their communities. They provide special attendance at Lions clubs and other community organisations that deliver targeted CPR awareness to older community members. And the QAS also has a strong presence at local community ag shows and fetes. Our Brisbane agricultural show starts this Friday, the Yeka, and we'll have a big presence there with our uniformed staff trying to expose as many people as possible to CPR. We also run awareness and skills sessions at other major events like schoolies, the V8 supercars, NAIDOC week celebrations, all kinds of things like that. Outpatient CPR awareness is delivered to parents at the Lady Salento Children's Hospital, which is the major tertiary facility, paediatric facility in Queensland. And each local ambulance service network conducts school and kindy visits, teaching CPR skills to our very youngest Queenslanders. We'll be excited to get involved in Restart a Heart Day as well. And really the reason for focusing on community CPR is that CPR skill exposure is low cost, it's accessible, and the skills are transferable across settings. They don't need any special equipment. It can be rolled out using a peer-to-peer model. And a focus on basic life support techniques such as community CPR is consistent with ILCOR guidelines and has demonstrated effectiveness. By recognising early quality CPR as the vital first link of the chain of survival, we can optimise the opportunities for the subsequent links in the chain to be effective. And by exposing as many Queensland residents as possible to CPR skills, we empower the community to recognise cardiac arrest, commence effective CPR quickly and confidently, and continue to perform good CPR until help arrives, ultimately improving the chances of survival for those who suffer an out-of-hospital cardiac arrest, which is probably going to be your family. And that's it. Thanks very much.